collaborative session, esophageal balloons, transpulmonary pressures, and volumetric capnography. So the alveoli. This is some background physiology for you. I'm sure you guys know about this, but alveoli are always wanting to collapse on themselves. The way that they were developed is we need to generate some negative pressure in order to generate a breath, and there are opposing forces in the lung and the chest wall that are equal and opposite at FRC. So here is a poorly drawn picture that, yeah, I did, but so we remember, because we're all therapists, we know inspiration is an active process. You have to generate a breath, and exhalation is passive. It just happens. So inspiration, generate negative pressure, air comes in, magic happens, air goes out. That's how you explain it. So we have a couple pressures that go in our respiratory system. We have up here, so we're going to try this laser pointer because there's a lot of graphs in it. Again, a poorly drawn rendition of what's going on in your lungs. Is we have our airway pressures, or our opening airway pressure would be our mouth pressure. Comes down. We have our interpleural pressures here, and our esophageal pressures here. And here is where you'll be seeing your esophageal balloon. There's a couple pressure gradients that we're going to see going on in our lungs. We have our trans-airway pressures, our transthoracic pressures, our transpulmonary pressure, and trans-respiratory pressure. So our pleural space is negative at rest. So it's never zero. It's always slightly negative. And that's because it's pulling on because our alveoli are always trying to collapse. Our interpleural pressure has to be a little bit negative just to make sure that doesn't happen. So when you inspire, interpleural pressure becomes more negative, not greater. It's more negative because it's a negative and a negative. And some of that negative pressure is generated into the alveoli. It's going to cause your pressure to be lower than your mouth, generate your inspiratory flow. And it's going to cause your alveoli to expand and your volume to come in. And this is just what it looks like if you had a graph. You have interpleural pressure, intrapulmonary pressure dropping slightly, coming back to baseline. Interpleural pressure stays negative the entire time until inspiration happens. Then it comes back to our slightly negative state, and then our passive exhalation, where it's just coming out. And that's how that one goes. Esophageal balloons. So we talked about compliance a lot, but I didn't give you the whole story about compliance. So I'm sorry, but it wasn't time. So when we look at compliance, there's actually two different types of compliance. We have the compliance of our airway and the compliance of our chest wall. So when we look at a ventilator, though, it doesn't know the difference between the two. It only measures total compliance. So the usefulness of the esophageal balloon is you can pop it into somebody's esophagus, and it's going to be able to tell you the difference between your airway and your chest wall compliance. And that's important in determining who's at risk for barotrauma. So when you look here, again, this was our alveolar pressure. It goes negative, back up. Esophageal pressure goes all the way down, just like the intrapulmonary pressure. So, or the transpleural pressure. So here we pop our balloon down, and it's going to give us kind of a reflective measurement of what's going on right next door, right in here. And just FYI, once the esophageal balloon is in proper place, first, it's going to be connected to something. It's not just going to be sitting here like this dude swallowed a balloon. And second, your heart is going to be right over top of it here. So once you're dropping this in, you're going to see some cardiac oscillations, and that's how you know it is properly positioned. So lung compliance. So lung compliance affects how much negative pressure can be generated and how big of a breath you can breathe in. So if you perform an inspiratory hold, your esophageal pressure is going to be compared to your airway, and it's going to give you some transpulmonary plateau pressure. And if you perform an expiratory hold, it's going to be compared again, calculates your transpulmonary positive and expiratory pressure. And it's important because it's going to give you an idea of how much pleural pressure must be overcome in order to prevent alveolar collapse. or this is going to be your critical opening pressure, which we talked about last week with that waterfall slide. So mathematically, your transpulmonary pressure, you're going to subtract your alveolar pressure and your pleural pressure. Normal people, it's about 3, and at maximum inspiration, you're going to get about 13. So one thing to remember is at any given compliance, so if you have 2 people with the identical compliances, the greater the transpulmonary pressure, the greater the lung volume that you're going to be able to generate. And that's important to remember because it sounds like an excellent test question. So just FYI, seeing if you're paying attention. So our risk for over-distension, so we know plateau pressures of over 30 are patients that are going to be at higher risk for getting some lung damage and alveolar damage. Esophageal balloons, once you put them in there, it's going to give you a proper measurement of your airway pressure. So let's say we have somebody with high compliance, so their lungs are easily inflated, and it's given us a plateau pressure of 40. So you walk in, and you're like, oh no, their plateau's over 30, they're at high risk for trauma. And we actually calculate it compared to your pleural pressure. When we do our math, we have our 40 minus 25, so we're only at 15 centimeters. So it's giving us our transpulmonary pressure. So what's going on is a lot of that plateau pressure is due to extrapulmonary causes. So that's going to be kind of some, maybe it's abdominal pressure, or they have ascites, or something's going on in their belly that's causing a lot of pressure to push up on their lungs. So we have a patient that's on a ventilator and they have ARDS, they don't have anything going on with their belly. You walk in and they have the same plateau pressure of 40, but you have your balloon that's giving you a pleural pressure of -10. Mathematically, you look at it, 40 minus -10, again, you have to add that algebraically, and we get 50. So that patient's at really high risk for over-distension. That's where the usefulness of this balloon is really going to be helping us. And here's just a couple examples of what's going on. So we have slide 1. This is a normal person breathing. We have an alveolar pressure of 0, a pleural pressure of -8. Calculated it out, we get a +8. We have it in this in B, and patient on a ventilator, paralyzed and sedated. He's comfortable, so he receives positive pressure and generates the same transpulmonary pressure of 8. So they have equal compliances and an equal transpulmonary pressure. So you have a patient in C that has high low compliance, intubated, and you can see there's a lot of pleural pressure going on. So while their alveolar pressure might be reading 30, their pleural pressure is reading 25. So when you actually calculate it out, is the transpulmonary pressure is only 5. So the reason why this guy's pleural pressure or alveolar pressure is so high, or plateau pressure, would just be because of the extrapulmonary stuff that's going on. So these alveoli are recruitable, but because of the extra cause that's going on, the total transpulmonary pressure isn't that bad. We have our trumpet player down in the bottom D. So this is somebody that's forcefully trying to take a breath and forcefully exhaling. So I forgot about my pointer. So we have an alveolar pressure of 150 and a pleural pressure of 140. So this person is using muscles. They're using their intercostals, their abs. They're contracting. They're trying to generate as high of a pressure as they can. But, we don't see, you'd think, hey, 150, oh, doesn't this guy have a pneumo? It's because his actual pressure that's going on, and the transpulmonary pressure is only 10. So that's why we don't see a lot of, trumpet players hitting their high notes and then collapsing because they, blew a pneumo or anything. In E, we have somebody in respiratory distress on non-invasive ventilation. Here, they're getting an alveolar pressure of 10, which is pretty low, but their pleural pressure is -15, so they're generating a lot of negative pressure. Because of that negative pressure, their transpulmonary pressure is all the way up to 25. So that patient is generating a high transpulmonary pressure because, again, they're using their muscles to breathe. And that's compared to, say, this guy up here who's paralyzed, sedated. I'm sorry, I need to get a drink there. He is not using any inspiratory muscles to inhale or exhale. So that's why his pressure is kind of low. But once you factor in positive pressure here and generating pressure here, by the patient, you're getting a pretty high transpulmonary pressure. Okay, now into our volumetric capnography. So we know VCO2 is the amount of volume of carbon dioxide eliminated through your lungs. It's going to show changes in your ventilation and perfusion. Go back to that VQ matching constantly. And yeah, you can monitor at a steady state. It's going to be reflected in your CO2 production. So we use it because it can validate the need for blood gas, non-invasive way of monitoring a patient, because it's a lot easier to continuously monitor end-tidal CO2 than it is to stick a patient every 4 hours, because there's more risk. There's a lot of risk associated with that. Say if you're entering somebody's vein that frequently, they're at high risk for blood loss or maybe an infection at the site. And plus, when you have a continuous monitor on, you're going to be able to rapidly see changes in your VQ matching compared to only when you get a gas. It can also be used for optimizing ventilation, and you can use it in moving. Again, we all love this picture. We have a shunt here, so we have perfusion with no ventilation, normal, ventilation without perfusion. Right here is our large conducting airways. So when we're measuring VCO2, we're going to be measuring what's going on here. And you're going to happen to see here because we have to go through here to get to here. And it's going to give us a reflection of what this number is, which would be our PaCO2. Our Bohr equation, that's just our dead space equation. It's going to be composed of our anatomical and our VLR dead space. So remember, it's our PaCO minus pico over PaCO. So let's go. Nothing too exciting to tell you. We had to remember this for our boards, so you might want to. Everyone's kind of done with it. I know I don't want to beat it into the ground. So our PaCO2 and our end-tidal, you're going to have a normal pressure gradient between the two of them, or a normal, it's a pressure measurement gradient. So it's normally 2 to 5. Differences in this are usually caused by lung disease. If you see this number being a lot higher, it's because you're having a problem with VQ mismatch. Maybe there's a shunt. Maybe there is perfusion or ventilation without perfusion, or ventilation or perfusion without ventilation. And if you see a change, it could show that. If you notice a change, it could show the patient's condition's worsening. Maybe it's improving though. Hopefully it's improving. We'll see here. And this is what it looks like. So I got a couple different versions of this to show you. So we have phase 1, phase 2, phase 3. Phase 1 is this is gas from the large airways. There's no CO2 because it's not participating in any ventilation. You have phase 2 where it goes up and plateaus. This is the CO2 curve at 50%. You can go from here to here, and this whole amount here is your airway dead space. And then over here, it goes up, plateaus, you get to phase 3, and this is all alveolar gas. So this whole area under the curve is alveolar gas. But if you look up here, you have our PaCO. So you look at the difference here, we have PaCO and pico. So remember, that is our dead space. So that is the amount of alveolar dead space that's going on. Hi. This is just another way to look at it. Remember, everything here under the curve is alveolar ventilation. Everything between your PaCO pico is dead space, and over here is just going to be airway dead space. So alveolar dead space, alveolar ventilation, airway dead space. Here's just another way of looking at it. It's the same slide, but some people, it takes a couple before it finally clicks. I know it works that way for me. And this is in volume percent instead of the actual millimeters of millimeters of mercury, I believe it's measured in. So PaCO is up here, pico is across here. Phase 1, 2, 3, 50%. So this is our anatomical large airway dead space. Up here should be, that's more airway dead space. Up here is the difference is dead space. Down here it's all alveolar gas exhaled. And this is some abnormal things you might see on it. So in here is our normal, goes up. What's going on here is somebody with a long time constant. So they have a mismatch, slow emptying. It doesn't get as high, and it has a long, long slope. There's a difference you're going to see here compared to normal. You're going to see you get to a point where it stabilizes, or it plateaus. That's going to be where you have something like a pulmonary embolism going on, so you're not getting any more CO2 out. But it might just, if it keeps going and keeps going and keeps going, it's usually some, an asthma exacerbation on a ventilator, somebody with COPD, whatever's going to cause that VQ mismatch. That's usually ventilation mismatch at that point instead of perfusion. But so yeah, ventilation there, perfusion there. Causes that you might see, anything that's going to increase your CO2 production or ventilator malfunction, and it's going to be cause decrease, is anything that's going to cause a decrease in metabolic production, or basically ventilators not hooked up, introduction of atmospheric gas, bad sampling, airway obstruction, not being in the airway, disconnect, and then your exhausted CO2 absorber. That's if you're using a closed system ventilator where somebody ends up rebreathing gas. And here's a couple of examples of things that you may be seeing. So this is a CO2 curve. We see it's about 15 every breath at starting, where inhalation should be 0 because you're not breathing in it, or it shouldn't be starting until you get up here. So it should be down here at 0. So what's going on here is a mechanically ventilated patient with a malfunctioning expiratory valve. CO2 level is elevated because the patient's exhaled breath is measured during inspiration. And what you need to do here is check your exhalation valve, probably change it out. What's going on in B is so we have, it looks good here, but it doesn't return to baseline. So basically what's going on here is maybe there's moisture or something blocking your sampling tube. Here is distortions from an incomplete exhalation. This may be caused by hiccups. They say chest compressions, but I don't completely agree with that, because that would be return if you're having perfusion going on, you'd have return of spontaneous perfusion, so you wouldn't really want to be doing compressions on somebody at that point. Here is that shark fin pattern. This would be somebody with COPD or long time constants, so it just trends all the time, then plateaus. E is a patient with a obstructive lung disease. There's no plateau for alveolar emptying, so it just keeps going up and up and up and up and up and then drops off. It doesn't hit that plateau point. I mean, it looks like it does here, but we're going to say it doesn't. This is because the alveoli are not emptying completely. Over here in F, this would be somebody that's actively trying to inhale during exhalation, so you're seeing a little dip there. E, it's cutting out a little bit for me, but you can see here this choppiness. This is uneven carbon dioxide levels seen at the end of expiration, caused by a patient's heart pumping fresh blood and CO2 the emptying lungs, or cardiac oscillations on the screen. And this is also could be caused by exhalation valve fluttering. So, and a good way to tell that is if you match those oscillations to the heart rate, it's going to be cardiac oscillations. And here is what we call a biphasic curve, or a biphasic plateau, and this may be seen in patients with lungs that have different compliance and VQ matching, so you might see this in maybe single lung transplant patients. Again, you can trend. Nothing really important to tell you about that. Remember, if you're hypoventilating, it goes up. Hyperventilating, it goes down. And here is what we can do for optimal PEEP. So what's going on in this slide is it's a CT. Dark areas are air. White areas are not air, I guess would be the best way to call it. So these are two patients. This example, they're on 5. So this patient has a lot of collapse going on. And this patient just has kind of a significant area of collapse here. So when we look over, they increased both of them to 45 centimeters for their PEEP. What happened on this patient was we see a lot more areas of darkness. So their ventilation went up. These alveoli were recruitable. So we added PEEP, we got to our opening pressure, and these patients opened up and they were able to improve their ventilation. But this patient down here is, we put as much PEEP as you want, nothing happened here. Remember, gas is going to follow the path of least resistance. So all of the gas went to here, so now this patient's going to have some VQ matching because these alveoli are overinflated. These ones are not inflated at all, so you're having a big VQ mismatch. For this one, it's pretty good because these alveoli are now participating when previously they weren't. So there gets to PEEP, so that would be optimal PEEP. This patient, you just have to turn it down because no matter what you do, you don't get that lung open. Maybe you have to bronch that guy and find out why. This part of the lung isn't taking place in ventilation. But so this is an example of an echo monitor. This is just one of the devices that are on the market. So we have a study that they did to determine optimal PEEP on a patient. They started here. They increased their CO2 a little bit, or their PEEP. And what we saw was initially a drop in CO2 because alveoli were being overinflated, and then it came back up right there. And what's going on is it corresponds with an increase in alveolar ventilation. So we look here, alveolar, CO2, and PEEP. So we saw an increase in alveolar ventilation, and they did it in a stepwise approach. So did it again, initial drop, recovered, and we still got an increase in alveolar ventilation. So this is that guy that would be in the top of the last picture because we turned up the PEEP, more alveoli participated, more CO2 was exhaled. Now you do get to a point though where you get over too much PEEP. You're beyond your optimal PEEP. So they went up, CO2 dropped, and it didn't recover. And you look down here, what happened was they didn't see any increase in alveolar ventilation. They actually saw a decrease in alveolar ventilation. So they decreased it back down to the 20, I believe, and CO2 recovered, alveolar ventilation recovered. So at this point, that would be optimal PEEP. And optimal PEEP is a good way to think of it being is when your oxygenation is the best, your CO2 is the least, because once you add any more pressure to that alveoli, you're going to be over-distended, and this CO2 is going to start going up while oxygenation goes down. So when oxygenation is best, the end-tidal CO2 will be the least. And this is some weaning trials you can do. These are just two patients, A and B. So this is the guy in bed 1, put him on his trial. Say you put, patient, we'll say a patient bed 1 and 2. Bed 1, put him on his trial. Bed 2, you want next door and flipped him over to. They're breathing. Oh, participating more. These are spontaneous breaths. And then you can see your CO2 increase. So the patient's breathing on their own, doing pretty well. Patient in bed 2, though, you can see they're breathing, and they peter out. And their CO2 also peters out. So this patient's able to be extubated, or I guess that'd be a successful weaning trial. This patient, not so successful. And that's all I have for this week. I know this one's pretty short, but I know you're probably ready for a little bit of a break. Next week, you will have an exam, but for this week, keep doing your discussion boards. You're still going to have those every week until the end of the course. Do your attestation of completion for watching the video, and there's that small quiz. And I was looking over the scores for the quiz. Right now, the scores haven't been the best, but don't worry, you can make up for it. And this quiz is actually probably the harder one out of all the ones I'll be giving you. But yeah, you'll have a quiz next week. Just FYI on it. It's going to be a lot of true-false, and just throwing a graph at you, telling you what it is, and saying, hey, what do you interpret this as being? So they're usually not too terrible. They're open books, so you can review your notes, and just shoot me an email, send me a text, give me a call if you have any questions. But other than that, hope you enjoyed the sessions with me. Lonnie will be taking over weeks 4 to 7, so he'll be doing the rest of the collaborates. And yeah, that's it. Well, good luck everybody, and let me know if you have any questions.